Hello, this is Dr. Hausinger. This PowerPoint covers chapters 9 and 15 of your Babor text, and we're going to look at services and systems for drug users. Services and systems are designed to meet the following goals. Abstinence, and we've talked a lot about this in the other CD classes as well. The primary driving force of the Say No to drugs and the war on drugs is abstinence-based education, which of course we know it doesn't work very well. It doesn't work very well for drugs. It doesn't work very well for sex. So we need to understand that people are people and that they're curious and they're going to be experimenting. Okay. The next type of goal would be reducing the amount or frequency, and that's where we get harm reduction. Okay. Things like needle exchanges, naloxone kits, drug testing kits, etc. And then the third goal is changing collateral behaviors that are associated with drug use, which is usually what the public becomes most inflamed about, such as criminal activity. Okay. And then we have the public health aspect of that, which would be needle sharing, etc. The assumption is that the micro level, so individual change, will translate into meso and macro level change, so a flowing up model, if you will. Some of the examples of harm reduction are medication-assisted treatment, and this is really driven in the healthcare system. They have methadone clinics, they have outpatient, a person can get this from their regular physician, so it's relatively widely available, and there aren't so many barriers to MATs depending on what it is. I would say that methadone clinics probably have the most oversight in terms of daily check-ins, case manager, etc. It just kind of depends on what the treatment is. Okay. We have maintenance and substitution therapy. So maintenance would be methadone maintenance, Suboxone, etc. It's rooted in harm reduction, in that these are controlled substances that are pharmaceutically manufactured and controlled in terms of what's in them, what's mixed with them, how it's cut, so to say, street language. And it's a lot less harmful for a person to go to the doctor's office, have a prescription, than to use IV heroin or to do the things that somebody might need to do in order to get drugs, especially if clean supplies aren't available. Now, that's not to say that sometimes things like methadone and Suboxone are traded or are sold. That's true. But in general, it's a lot less harmful. And the focus here is on public health, really with reducing exposure and transmission of infectious diseases. Some of the examples of medication would be nicotine gum and nicotine patches. If a person was to call the tobacco quit line, they might be given some free samples of this, and they have certified quit coaches that work with you live over the phone to help you come up with a quit day. Methadone is probably the oldest maintenance program that people are aware of, and the goal can be to help somebody get off of opiates. Sometimes they do use methadone to treat pain, really heavy-duty pain, maybe for cancer patients or something very, very chronic. Then we have Suboxone, which can be in a sublingual strip or a pill. The Vivitrol is an injection, very much like a birth control injection, and it lasts about 28 days. And a lot of people do this right before they leave treatment as an insurance policy. The issue with Vivitrol is that it does block the opiate receptors, but if a person kept trying to inject themselves to get high, they're not going to feel it, but they could overdose. Okay. Then we have naloxone, which is Narcan, which will take somebody out of an overdose. And then, of course, we have naltrexone, which is used both for alcohol and for opiates. Okay. Now, looking specifically at the main medications for substances, we have methadone, buprenorphine, which is Suboxone, and naltrexone. Actually, I made a mistake because they sound exactly the same. We're going to switch these right here. Naloxone is the Narcan, and naltrexone is often used for alcohol. Okay, but naltrexone is an opiate blocker. Okay, right. We have antabuse, which is the pill that if somebody takes it and then drinks on it, they'll become violently ill. It's aversion therapy. It's rooted in behavioral therapy. So as to no longer associate alcohol use with something positive, but to associate it with something negative. Okay. And then we have acamprosate as well. Okay. And then another example of a medication would be Chantrix. Okay. These are not without their ups and downs and their side effects as well. One of the side effects of Chantrix is that it causes intense lucid dreaming. We have opiate substitution therapy. The most widely used one is methadone. It's outpatient based. Usually, patients need to prove themselves for a period of time and have a daily relationship with a clinic, and then they can get what is called a carry. So, if they're going on vacation or if they're going to be out of town or unable to access a methadone treatment center or they can't get a transfer, they might be able to have a carry where they can take it on them. It's not rapid release like heroin. It's a 24-hour release. It can be in a pill or in a liquid. It doesn't taste very well, I've been told. Some pros of this is that you have the daily engagement by patrons. And usually, if it's run by a health department or another clinic, there are case managers and counselors and access to other services as well. So having that daily engagement is harm reduction in and of itself. It is the longest used MAT, and it is very cost effective. Cons to this is, from what I've been told, that withdrawals from methadone can be very painful, maybe even more so painful than withdrawals from the opiate. What many patients do is they do a blind dose and a taper so that they don't know how many milligrams that they are on. And the counselor and the doctors, of course, are the ones who know. And so then they begin a taper, and a lot of people find that to be very helpful. Then we have buprenorphine or Suboxone, also outpatient based. It is less regulated and allows more primary care providers to prescribe it. And we see a lot of places that just kind of popped up to offer it. A con to this is that there's not a ton of oversight, so that people might not be engaging in the behavioral modification aspect as well, just the pill. Okay. So you have the sublingual form, which is like the Listerine strip, and a tablet form. Okay, that has naloxone in it, which is the opiate antagonist. Okay, and it is also cost effective. Okay. We have opiate antagonists. Naltrexone is an opiate blocker. That's the Vivitrol injection. The person has to be clear of opiates to have it in their system. It blocks the effects of opiate, and it's a sustained release. Again, it lasts about 28 days. And then you have the Narcan nasal spray. The public is a little shy in general of using needles. So originally they were having the Narcan available, like EpiPens, but they found that Good Samaritans and others were really hesitant to use that, so they developed the Narcan nasal spray. Okay. Some of the common treatment systems and models that you'll run into include behavioral and psychosocial, which is the treatment, so inpatient, outpatient, CBT, all of that we cover in 401. Contingency management has been very helpful with certain populations, particularly those that might be difficult to engage. The VA uses it, and it can be very helpful with homeless shelters as well. So this is, you're doing so well and you get rewarded with a voucher or a service, etc. Okay. It's kind of like the sticker method. You get a sticker for only it's an actual service. Family interventions. A person can do an intervention without having a counselor. Intervention is an industry, and it can cost about $1,500 to $3,000 for an intervention. But this is something that might be linked to a treatment center or included with that. We have cognitive behavioral therapy, which can be used individually and in groups, and it's very cost effective and very evidence-based, and it works really well with other therapies as well, so you can add it to things. Brief motivational interventions have been found to be very effective and helping people move past ambiguity. Therapeutic communities are often found in jails and prisons, and they're usually elective programs where a person can choose to be part of a community where they abide by certain rules and regulations, and it's very much a peer supported environment. And then we have harm reduction services, which can include many different things. So some of the common treatment systems and models that we have are needle exchanges and non-prescription needles, so that person wouldn't need a prescription to get that. Emergency naloxone, which is Narcan availability. Okay? And more pharmacies have been having this so that anybody can go in and buy it and carry it on their person. They're also arming police officers and first responders with this as well. There's the supervised injection centers. We're looking more and more towards this in the United States. Seattle is going through a battle with this right now in terms of where they're going to do it, and they're looking more at the mobile clinics. We have the peer-led self-help organizations like Recovery Coaching and 12-Step, which you're very familiar with from 400 and 401. Smart Recovery is self-managed and recovery training. It's one of the many alternatives to 12-Step. And then we have sober living and housing. So, for example, Oxford House. This is really important to note that some housing is regulated in terms of you have case managers and counselors, and it's an actual agency like DESC in Seattle. And then you have kind of private organizations where volunteers do it, like Oxford House, but it's not really regulated. So it's kind of on a house by house basis whether or not people are being sober. There have been issues with people dealing drugs out of these houses and running prostitution rings. It happens every so often on the news. So when we say sober living and housing, it's an umbrella term. Okay? So you're going to see, differences here. Wet housing is a housing first model in which we say that everybody needs housing, and then if we house people first, then the other issues can get addressed more easily, and is actually much more cost effective to put people into housing rather than to try to chase them and track them down when they're not in a centralized location. And it's also harm reducing in that people are safer. They might not need to do things that they would do in order to get housing for the night, etc. Okay. We have criminal justice system interventions. One of the things that's really common is if somebody gets a DUI for drugs or alcohol, the judge will say, you can't use, you are hereby ordered not to use. It's called a no-use court mandate. And usually it's from the time that they get the DUI and the court order to the time that they have the drug and alcohol assessment. This is coupled with mandatory UAs and drug screenings. We have drug court programs, which have been very successful. They really are a unique blend of social services and criminal justice. This week in your Moodle module, you have the examples of the Thurston County Drug Court. And then we have prison mandated treatment, where a person goes in and they have to have treatment. And then we have the opt-in therapeutic communities. So when we watched Seattle is Dying, the Rhode Island model is the prison mandated treatment. Looking at the systems of care for drug users, we have specialized drug and alcohol services, psychiatric care, general medical care system, such as a person's primary care provider, the criminal justice prison system, which sometimes is a catch-all when people cannot access when they can't access mental health services. And we have the social welfare system, and then we have the voluntary sector. So all of these different levels of services. Now, some of the qualities and considerations of the service systems is we have to look at, are they accessible? Do people know about them? Can they access them? You can't access something you don't know about it. How do we coordinate a person's needs, especially if they are advanced and complex between the different service systems? What are the economical effects of treating people versus not treating people? Then we have the issue of coerciveness. At what point do we mandate somebody to go to treatment? Okay, such as in the Rhode Island model that we saw with Seattle is Dying. And then what are the stigmas associated with this? So looking at innovations for success, We see the primary care integration models, um, which helped us move towards co-occurring treatment so that a person wouldn't have to have separate services in a separate building. They could access mental health and drug and alcohol counseling within the same services, using and also having the primary care provider, their doctor, as the gatekeeper for that. One of the issues that we saw is that a lot of people, surprise, surprise, didn't tell their doctors about their drinking or about their drug use. And unless they're going to UA and test for that, or unless it's painfully obvious, um, the doctor might not know that, which can complicate things. Okay. Looking at service coordination, so this is the role of the case manager as a liaison to help coordinate all of the different things that a person might need. Effective programming reduces drug use while increasing employment. So if we look at the Portugal model, this is also true of the Scandinavian countries where their jail model is very, very, very different, and it's more rehabilitative. In the Norwegian Scandinavian countries, the prison model is a lot less punitive, and they work on building relationships with people on the outside, college, vocational training, self-esteem training, etc. Okay. Great. So then we need to look at where is the balance in credentials. We're kind of uneven at this point. So for example, we have master's level counselors for mental health, but a person only needs an associate's degree in order to be a drug and alcohol counselor. Is that an ethical issue? Is that a training issue? Early on, a person didn't need to have any education in order to be a drug and alcohol counselor. All they needed to do was to have graduated themselves from the 12 steps, which we know 12-step is great, but it's not actual treatment. It's peer support and should not be a substitution for treatment. Okay. It's different, but it's been used as a catch-all. So we need to look at where is the balance, how much education, what type of education is enough? Are we educating people enough? Are we turning out good, competent professionals or not? So that's the question, how much education is really needed? And it's difficult to measure this and to track the effectiveness. So since 2014, SAMHSA has really been trying to figure out what are we doing or what can be done on a federal level. Part of this is that each state governs their own requirements, okay? And they're not always transferable. There is a website where you can look to see if the credential, what you would need to do to transfer it. So for example, if you went from Washington to California, or if you went from New York to Washington, what that would look like. And the credential is not just going to transfer. So in some states, there's more training that's needed than others, and so you might just need to take a test. In other states, they might want you to take a test and take more classes, etc. So it's very much not something that's federally regulated in terms of state to state and what the education requirements are. Okay, so this is something that we can talk about and look at. What are the ethical ramifications here if we want mental health counselors to have master's degrees, and that's what we say is a level of competence with 2,000 hours of internship or whatnot? Why are we not doing that with CD counselors? Are we saying that without having things even, that are we making CD less of a field? Is it something less professional? So some things to think about. Thank you.